Okay. 1, 2. Okay, I'd like to introduce Doug Murdock. Dr. Murdock, he works at the ER. He can give more information about what he does. He's been with the team kind of for how many years? Almost as many as me. Except you were like, I joined at 14, you joined at 5 or something. 85, okay. Anyway, I'll just turn it over to him. He's got some things he wants to show us, and he usually is very good, so appreciate him being here. And I go down and see him once in a while, but every time I go down there, he does bad things to me, so I don't go see him so much anymore.
All right, we'll see how that works. If I talk too loud, you let me know. I'm just notorious for escalating my voice because I don't like mics, so I can usually talk to you without anything. But for those of you sitting in the back, I'll use it. So, as Glenn said, I've been sort of with the turf. I say sort of because lately I've fallen off the mountain, literally. I still go up in the hills. I disappear in the Uintas a lot. But my ER schedule is just kind of messed up. It's a lame excuse. And then I get myself so involved with EMS and medical director positions. But I have a great time. I love emergency medicine. I started out in EMS in '85, running the ambulance for over 25 years. Political things happened. They kicked me out because the county manager didn't like me. So it was an interesting process. But I still work with Grand County. I'm over their EMS services. So that's Moab Group. I still work with Turton. I love to do that. BYU, UVU, EMS. So I keep my hands involved in things. I like it. So when Glenn and others asked me to come back today, I was thrilled to have the opportunity, especially where my schedule was sort of conducive. So I had to sleep in the ER so I could be here right now. I got up this morning. And I just changed my plans this morning because I said, no, we're going to do something totally different here. So a lot of times I like to talk about, the medicine aspect of things, and it's important, and we will talk about it today. We're going to change things a little bit. So irregardless of whether you're medically trained or not, if you claim to be a radio operator only, or a runner, or a climber, whatever your position may be, that's far from the truth. You are all medical providers. Things I'm going to teach you today, understand you are not licensed to do what I'm going to teach you. This is called wilderness medicine. This is not stuff you get to use on the streets. If you do, I didn't teach you a thing, okay? So I'm not claiming anything. All right, so the idea is you get out in the wilderness. Of course, you see a lot of these pictures will be up in the Uintas because that's where I love to live in the summer if I can. And in the winters, I do too. You just don't see as many pictures. But we love to get out in the wilderness setting, and of course, Timpanogos is wilderness. And you're on your own, and it's really important to understand that. Because I don't want you to call search and rescue to come find you at some point in your life, or have to come rescue anybody for that matter. Ooh, that's fun. I got lots of them over here.
Where's that Coban?
We'll screw it in and see if we get a better connection. Never had a problem with my connection, but I happen to have a cable of my own if we need it. So.
Ryan can fix anything.
So what do you need?
Piece of tape.
See, this one goes to there. Cable. I think I've got another one in here.
I've got a 50-footer if we need it. So.
Maybe we can just plug straight into there and just bypass that. That's the problem.
We'll just tweak it a little bit. Nobody breathe, okay? You wanted to see those search and rescue guys, didn't you? All right, so anyway, let's get to some of the other things here. I don't know if I want those. I can't see in the back, but I can see if you raise your hands, though. Take your training, all the stuff you've done in EMS or first aid or even stuff your mom and grandma taught you. I don't care where your EMS experience comes from. But in the wilderness setting, you need to learn to improvise, and you all know that. Problem is we're not really good about improvising anymore. If you want a radio nowadays, you go to the store and you buy yourself a radio. How many of you are old enough to remember when you built your own radio? I did. See all the hands going up? Nowadays, the new generation coming up, unfortunately those of you who are younger here, I'm going to pick on you. You buy everything. You get in the store what you need. When is the last time some of you took home some type of device out of the dump and tore it apart to figure out how it worked? You need to do that in your life. And it doesn't change with medicine. You need to learn to improvise. You need to take what you have in your hands and make it work for your needs, not buy what you need. We'll have a little fun with this as we go through there. One of the big things out in the wilderness that kill people. I want you to hone in on those things and think about it. So if something happens up on the 13, you have a patient that you're called to. What's going to kill your patient? What are the two big ones, do you think? There you go. Trauma is one of the big ones, and anaphylaxis. You should be so good at those two things because those are your top two killers out in the wilderness setting. But again, you can't take a big, massive medical kit with you. We have decent ones up there, but the further out you go, the less equipment you're going to have. And so I had my kids rendezvous with me halfway down the canyon and said, bring some stuff, I need some things. They didn't bring my survival and first aid kit. The whole thing fits in the 1 liter bottle. It's always watertight. It's not just my survival kit, it's also my first aid kit. Everything I need for emergencies is in there. You're thinking, well, you can't possibly put all these big wire splints and you can't put air traction. No, I don't need it. Those aren't emergency equipment items. I want stuff that I'm going to improvise with that's going to save a life, and it fits in my little 1 liter bottle. All right, so we're going to cruise through improvisation just because I want to save some time. What you need to put in there, of course, things that you know what's in your bottle, and then things you thought through. So if I come over and I'll just pick a random item off the front, let's just choose a syringe, a 3cc syringe, or even pick a smaller one. Maybe you happen to be a diabetic and you happen to have a TB syringe or an insulin syringe with you. What can you possibly do with a wimpy little syringe? Trust me, you can save a life so dang fast, and I'm going to show you how in a second. But you need to know what's in your bottle or your first aid kit. These things, first aid kits, oh, they're neat. You can, Adventure Medical Kits, all these different companies that make them, they're neat to have. Problem is, many people don't know what they even have in their kits. Somewhere, there's this one. Your survival in a can. Neat little item. How many of you ever bought one of those things? Or survival in a can that looks like a sardine can. I got one over there too. The problem is, they're sealed. Now that's real nifty. You have no clue what's in there until you've opened the can. So now you have to open your sardine can, experiment with what's in there. The other issue is, this stuff is sold to do what? Make money. This is sold by price point. It's not sold to give you the ultimate equipment. If you want to make a killing as an industry, you create your own survival gear and you put top-notch stuff in there. But even better, I tell you, don't waste your money. You go buy each individual item and you make your own kit because you know what's in there. And not only that, you start practicing with your kits. So not just knowing what's in there, but how to improvise, how to have a little fun with it and take it way away from what it's intended to be used for. And there are things in this room we're gonna have a little fun. I won't cut your stuff, but I'd like to. All right, talk about anaphylaxis. And you can read through really fast. You say, well, anaphylaxis, what do I do for somebody who's having a true allergic reaction? Don't give me these little bumps on your skin or my eyes are a little puffy. I'm talking anaphylaxis. Right? Somebody got into some nuts they're allergic to, or they got stung by a bee. And they're truly allergic. What do you do for those people? Do you have an EpiPen up there? I hope not, because it's an absolute waste of money. At $80 a pop, in fact, you have to buy 2 of them now together, so you're usually spending about $180 to $200. They're expired in a year and a half, and you get to replace them. For heaven's sakes, if you want to buy an EpiPen, go buy a 1 milligram ampule of epinephrine, and it costs you about 47 cents. Yeah, so you have to learn what's out there, but most people don't carry epinephrine with them. And you're thinking, well, we'd like to. I say, fine, I'll give you authorization to carry Epi on the team. I don't care, it's fine with me. Just accidentally shoot them up and say you never did anything. But there are things you might happen to have. So we go through some of these little classic things. How many people pack Prometine mist out there? Or asthmanephrine, things that people use for the asthma stuff. They're albuterol medicines. These are all great things you can use for allergic reactions. Benadryl works very good. Unfortunately, it takes a little while unless you give it injectable, but Benadryl, if you get it in soon and give them 2, 3, or 4 pills, great. Don't give them 20 because they'll actually freak out on you. It's kind of cool to watch. But Benadryl is a great medicine. But then you get down to things, Zantac and Pepsin. Why in the heck would I give somebody Zantac or Pepsin for an anaphylactic reaction? Anybody have a clue on that one? They're not having stomach problems, and that's where most of you would recognize that medicine. Anybody, come on. I don't care if you're a doctor, nurse.
It's the pH.
No?
No?
Wait a minute here. It's a stomach medicine. What is this better known as, Zantac and Pepsin? What are they called?
Acid reducer.
Right? What kind? How does it work?
Proton pump inhibitors.
No, that's your omeprazole and Acifax and Prilosec. H2 blocker. He wants to be an H1 blocker. These are H2 blockers. Okay? So histamine, you've heard that term, causes release of acid, causes your ulcers to flare up. So they block H2, which is a histamine 2 release. Well, the neat thing about Zantac and Pepsin, it blocks H1. Histamine 1 is what causes your anaphylactic reaction. You take a Zantac or Pepsin, it lasts for 24 hours, does a marvelous job in abating a true anaphylactic response. So you start asking around for people, do you have any Zantac or Pepsin? And the guy's coughing up blue, and you're like, this guy's weird. Why would you want Zantac? Trust me. Great medicine. So instead of, if you have an allergy response, let's say you're at home and your kids have got the hives, etc., you don't want to take them in, that's fine. Give them a Zantac or Pepsin. Well, that's a little Benadryl initially, but after the initial dose, let the Zantac and Pepsin work. You're not drowsy, you're functioning just fine in the last couple 24 hours. Cool medicines. So again, H2 blockers, steroids. How many people packing steroids with them? You think, no, I'm not talking buff steroids, I'm talking prednisone. A lot of people have prednisone on them. They take it all the time. Don't want to, but a lot of people do. Steroids, that's what we give them in the ER. We tend to give it IV if they're truly having bad reactions. So, just fun. All right, let's talk more about airway issues. The tongue. Well, great. Okay, now they're unconscious and you have to control their airway, your head tilt, chin lift, or be careful as he's fine. We know about all that, but then you're stuck. And it's you. You're the only person who's helping me and I'm dying. I'm unconscious and you're helping my airway. Now you do this kind of thing and now what? Where are you going to go? What are you going to do? You're going to let go and go back to your bag and like, you can't. You need to figure out airway control. Now, how are you going to control my airway? Well, nasal trumpet's a great thing. You're thinking, I don't have a bunch of nasal airways in my pocket. Oh, you have a whole bunch of nasal airways with you. Where are your nasal airways? In this room as I speak. Somebody has them. What are you going to use?
Water bladder.
Water bladder. Too big of a bladder, but what's
The tube.
the tube from your camelback, your water bladder? It's a great nasal airway. Cut off one end, slip it down, shorten it to what you need to, make sure it doesn't suck into your lungs. You can tie a little string on it so it doesn't fall in. You've got an instant airway. What else we got? I saw a hand. The pin, we're going to get to that because that's kind of hard to put down the back of the nose, but I want you to save that pin because we're going to use it. We're going to tear it apart in a second. Yeah. What else is out there? What do you put in your backpack that has a hose to it? Water filter. I'm hearing pumps. Water filter? Absolutely. It's a nice flexible hose. And you can go on from there. Anything that's a hose that's flexible, it's going to go down through your nose and maybe behind your tongue to keep your tongue off the back of your throat is an instant nasal airway. You be creative. There are no rules in improvising. The exception, do not harm your patient. Right? That's the only rule in improvising. So find some type of fun little nasal airway. And I got a bunch of tubes over here and they all work just fine. If you are a true wilderness survival person, you should actually have some surgical tubing with you. You should always have surgical tubing. And if you ever have one in a wilderness medicine lecture or wilderness survival, that's a lot of fun to do that. But there's a whole bunch of things you can do with surgical tubing. All right. Now the next thing, and there's some safety pins up here. I say just take the safety pin, stick it through their end of your tongue, a big bite of it, not the very tip, and just pull it down and you pin it right to their chin. And you've got an instant open airway. Okay? They don't know anything. They're not going to feel it. They're unresponsive. So just pin it right to their chin. Mm-hmm. Yeah, it works really slick. It looks weird, but it works really well. Okay. What is that thing? Come on, there it is. This is the last choking victim I had.
What is that?
Brussels.
You are correct. I don't know Brussels sprouts until this poor lady died from it. Anyway, so, and this is a lesson for you, those of you who like to practice airway management. Paramedics put a tube in her, and they didn't see that the tube was in the esophagus, but she was dead anyway. But be careful about those things. That was a Brussels sprout. All right, now we have a surgical emergency, or an airway emergency. You can't get it out. How many carry a gill forceps up there with an intubation blade? Most of you don't. So what's your next step in survival for this patient? What are you going to do? You need an airway. What are you going to do with that?
Oh, the trach tube.
There you go. He's going to take that pen out of his pocket and he's going to do a little MacGyver stuff, right? We're going to do a cricothyrotomy. How many of you have ever done one? Oh, very cool. All right. You're thinking, I don't have a fancy $200 cric kit. It's because you don't need to buy them because they're an absolute waste of money. All right? Who has a knife on? I want a knife, not a little dinky thing. I need a knife.
In that box.
I know, but they're packaged. Okay. Watch how slick this is. Thank you.
Big old blade.
Remember I told you about my little syringe? Pop that little thing off, just like that. I now have a very sharp little thing. I make a little slit with my knife. Good sharp knife, that's a good thing. You make a little slit in the cricothyroid membrane. You slide that right on through. It's already got your end, so it can't slide down to the airway. And you have something you can actually ventilate through right there. If you take a standard needle, you take the catheter out, it'll actually plug right into that, and you can actually bag somebody. If you have a 3.5 endotracheal tube, you know what ET tubes are? You just pop the end off, it slides right in, it plugs in, you can now bag them right through that little thing. I'm not hunting for gear. It's boom, slice it, dice it, shove it down, and you're good. So, next thing is, all right, if you happen to have, many of you might be advanced intermediates or advanced, or you do IV therapy. This is my favorite one. This is what I do in the ER. Because I don't want them to have to find the cric kit because nobody ever seems to know where it's at. It seems to migrate. Infinite wisdom that people have, the pencil pushers in the ER like to come in and rearrange the trauma bays once in a while. And they never tell anybody where stuff is. So I say, okay, give me some IV tubing. And they give me some IV tubing. Very straightforward, comes in a little straightforward package, like that stuff. All I do is I take that end that's designed to puncture into the IV bag. You see that sharp little device? I can make a little nick in their neck, pop that thing right through, and the nifty thing is the bag valve fits right in the end of that chamber. You notice I cut the chamber off a little bit. Instant cricothyroidotomy. Isn't that fun? You're thinking, I'm not licensed to do that. Yeah, you're not. You're going to die if you don't. Hey, can you be sued for doing this? You betcha. Right? But you have to make the call. Again, that's why I'm teaching you fun things that you may not want to do. I'll tell them, it's your family, slice poke, bag. And it doesn't take you more than probably 20 seconds to do it. Formal cricothyroidotomy things, they take a longer time. You have to pull this sterile package open, you're supposed to clean everything, then you have to put the stylet or the needle through, then you have to put the trocar down through. Now, it's just pop that end off the syringe I showed you, or do one of those things. Super fast and very easy. All right? Isn't that kind of fun? All right. Now, this, the Poisson's law, you need to understand, you can't put a big long tube on somebody except can breathe through it. The shorter, the better. Long tubes, you can't breathe through very well. If I give you a straw, that's a regular Slurpee straw, and say run around the room 3 times, most of you wouldn't be able to do it. You'd be sucking air. I can't breathe anymore. You cut it to 1 inch long, you can run all day long. So think about shorter the better, whether it's a nasal airway or something like a cric airway. Now, we'll skip Poisson's law. All right, so face stuff. Yeah, we'll do that one. I better put this down because I'm a little dangerous now. Just swing it around.
I think I can't breathe.
Yeah, he can't breathe. So he's obviously got nasal, facial injury. He's got a lot of blood up in his nose. He's not going to put a nasal airway up there. The biggest thing on epistax, which is bloody noses, is how to take care of him, what do you do about him up in the wilderness setting. And it doesn't make a difference if you're wilderness or a home. But the point is, 1, You can't leave clots in there like this. Now this guy's not really able to help himself, so I'm not going to pick on him. First of all, nosebleeds, you must get the clots out. If you leave those things there, they'll bleed and bleed. It will not stop. Okay? That's just how it is. It doesn't matter where the location of the bleeder is. If it's your nose, your arm, if it's vaginal bleeding, somebody's having dysfunctional uterine bleeding, and they're bleeding, you've got to get the clots out. Otherwise, you bleed and bleed and bleed. A woman who just had a baby, they need a D&C to clean things out once in a while. It's the same concept. So with nosebleeds, got to get the clots out. You tell them to blow your nose. Now, I didn't say blow side to side super hard. Just blow the clots out. It's amazing how big they are. A lot of times they're actually coagulating and they're hanging down the back of their throat. So when you blow them out, you pull them out, it's really about that long, and they gag on you a little bit. Once you get the clots out, you simply push and push up. So in, up against the bone. If you simply push in, that's nifty. But when you push on your own nose, push in and up against the bone hard, you're going to feel it's painful. It's because you're cutting your circulation off to your nose. But that's the point, right? In, up, lean forward, 10 minutes, no peeking, pretty much stop any nosebleed. All right, what if it doesn't stop a nosebleed, then what are you going to use? All right, I brought up the feminine side of things, but it's probably buried so bad in here. I know it was just sitting there a second ago. Feminine napkins, I think they're great, right? Your tampons, they work well. They're just a little big for the average nose, but they work really nice. You can use all kinds of fun little devices like these things. You should all have a Foley catheter in your kit for many, many different reasons. The Foley catheters, if this is a posterior bleed, you can't pinch on them. You can't put your finger on them. You have to go back and stop the bleeding from behind. So all you have to do is put a Foley catheter down your nose, blow up the balloon a little bit, pull it up until it meets resistance. That way the blood can't go back down your throat. And it'll put a little pressure back there. Plus, when you pull on it a little bit, it'll actually restrict the blood flow to the posterior aspect of your nose. So, simple way to stop it. And if you really want to do it, you put that back in, pull it forward, make sure it's not dripping in the back of your throat, and you pack the front of the nose so it has nowhere to go. It'll tamponade or plot itself off. But it's uncomfortable, but a cool little device to have. It sounds for a lot more reasons than you might think. All right. There's lots of other things. Vaseline packing. If you happen to have Afrin or Neosynephrine, it's a very commonly used medicine people have in their packs. It's widely abused, but Afrin's a great thing. It constricts the vessels down. What do we use in the ER to constrict the nasal vascular structures? Any idea?
Cocaine.
You are correct. We use cocaine. Yeah, so I'm not advocating you suggest that anybody have cocaine on them, but it really works well, I must say. So, but we use a liquid cocaine, very small percentage. You don't get a buzz, unfortunately. All right. So the posterior bleeds we talked about. Eyes. Be careful about your eyes, especially if you think, it's a nice summer day. Yeah, you're sitting there watching that snowfield up there. And this may be funny, but I'm telling you, for half a cent, you can make some pretty good snow glasses. I can see just fine. It's just a pair of some duct tape. I took some strapping out of my underwear, and I cut some slits, and you can see perfectly fine. That's going to prevent me from being snowblind. Now, up in the temp area, you're not going to have a hard time. But true wilderness, you want to prevent snow blindness because it's an absolutely miserable thing. Your cornea gets burned. So every little spot on there is a burn that's taking up what's called fluorescein stain when we look at these eyes. It is miserable to have. You do not want it. You don't want anybody else to have the problem. The way to treat it, one, you don't rub it. You take some ibuprofen, give them a good dose of ibuprofen, like 800 milligrams. Cold packs helps. Keep your eyes closed. It's nice if you have some numbing eye drops, but most of us aren't going to have that kind of stuff. Foreign bodies in the eye. If you want to ask questions, let me know. But I have so much here, we're going to fly. Okay? So foreign bodies, yeah, don't pull things out of the eyeball. That's just common sense. Been taught that. Just common sense. If there's stuff in the eye, you got to wash it out gently. No high pressure stuff, but medium pressure is a good idea. You got to learn to pull the eyelids down. You got to learn to double evert the eyelids. You flip it up and you flip it up again. You don't know how, you come up and ask me afterwards. It's fun to do. If you want to use things to get things out of the eyeball, 18-gauge needle is my favorite by far. But you have to have a very steady hand. It can have a little nice resting tremor, obviously. But you can flick things off super easy. But if you don't know what you're doing, don't do it. You have to come in at a side angle. You don't go straight at them, obviously. But anyway, something you can think about. Cotton tip swabs for you, the easiest way, or the corner of a simple cotton t-shirt. Works just fine for getting most foreign bodies out. You look at some of these eyes, the top one looks terrible. They walk in the ER and they say, Doc, I'm going to die. Look at my eyeball, I'm going to go blind. I says, you can go home now. It's a benign nuisance. It's called a scleral hemorrhage. You bleed in the white of your eye. Won't cause any problems. Won't make you blind. You get to go home and you're done. The bottom one, you can see this kind of a darker line. That's blood in the anterior chamber. That's called a hyphema. That's a bigger deal. If you saw that on the mountain, don't call a helicopter. Don't call search and rescue. Just tell them to go down and go see the doctor when you get a chance. If it's completely filled up the entire anterior chamber, so you can't see anything as far as the colored part of their eye or their pupil, a little bigger concern. Again, it's not an emergency. They just need to go see the ophthalmologist sooner than later. So we say, go up the mountain, go see your doc, go to the ER, get the ophthalmologist to look at it. I don't care what caused it. It doesn't make any difference. You're not going to save anybody by flying them off the mountain. It's not going to save their eyeball. It's just one of those things that happens. Dental injuries. That's a tooth up there. You can see how long they are, much longer than the average person might think they are. If the whole thing's come out of its socket, what do? Well, one, you just wash it off gently in some water. You notice I said rinse it. You do not scrub it. If you look at that tooth and you say, ooh, there's that stringy stuff, I'm going to wash that off, and you polish it up beautiful, you might as well just throw it in the garbage can. It will not take. You just throw it away. So you rinse it. Do not rub it. Don't touch anything but this part of your tooth. So the root of it, leave it alone. Rinse it, put it right back up in the socket. It's kind of fun because most of them, when you put it back up, and you go, it just sinks right in there. And then if you can, if you happen to have some way to glue it on there or tape it on there, you tape it to a good tooth, or super glue one good tooth and the next works just fine. You want it in the socket as soon as possible. So you can say, well, you can put it in the corner of your mouth and you can keep it in your own saliva. Yeah, that works, but the problem is by the time you get off the mouth and down to get some help, the tooth's dying and it doesn't take well. So put it back in as soon as you can. Rinse it, shove it back up in there. Don't put it backwards. That's embarrassing. All right. The bottom you can't see well. It's a broken tooth. They hurt. Not much you can do about it. Sometimes if you have some topical gel on you, like the mouth sore gels, that helps, but just some ibuprofen. If you can cover it so it's not exposed to the air, put a wad of gum over it. That actually works okay. What's the best gum? Anybody know?
Cheese-up.
Never tried it. I don't know. Maybe it works. It covers it. Cloves. Yeah. That old gum, the clove gum. Yeah. We actually, if you have a socket that's open from your dentist, we'll actually pack cloves down in there. Tastes kind of good too. Anyway, foreign bodies, another one. All right, so you get, and the classic thing is meat gets stuck down in your esophagus. How do you get it out? I mean, I've had this. I've been out pacing outside the restaurant, drooling for a while, trying to get something down. I have since fixed my stomach, so I'm good. But this happens all the time. Every day we see esophageal foreign bodies. Most of it's going to be meat. How do you get it to pass on through? They come to you 12 o'clock at night, of course, from your camp just above you and say, I can't swallow, I can't get my water down, nothing, I'm drooling, I swallow, I throw up. They don't throw up, they just bring up what's in their esophagus. Well, there's some simple things. If you happen to have some nitro on hand from somebody, be careful with the blood pressure, but it works rarely, but you can try it. Some people try glucagon. People have that for their diabetes. That will relax the smooth muscles, but again, only works rarely, but it's not worth it. It doesn't hurt to try it. Fizzy stuff, Alka-Seltzers, that kind of thing, but some people will try and hold it there and let the pressure build up, and then poof, they perforate their esophagus. So be very careful about that. But if you want to try a Coca-Cola, a Sprite that's got a little fizz to it, yeah, it's okay, you can give it a try. After 28 years of watching people do these things, they don't work very good. But I see I'm a little skewed because I see most of those who fail and end up with me. If it doesn't work, you can sometimes try narcotics, but you have to do it injectable because you can't swallow the narcotic, obviously. So what else do you do? How do you get them out? Anybody know? You can't. They've tried. Well, that's my favorite little buddy here. Oh, yeah. Get that catheter out, all right? And you feed that nice little, and you can't use a little pediatric wimpy thing. You've got to have a decent stiff catheter because you need to slide this all the way down past that foreign body. And you blow up the balloon with a little water, and you gently just start working it right back up and out. And it actually works really good. I'm talking 98% effective if you can get it past the foreign body.
That's amazing.
Save yourself a $4,500 bill, too.
Do you carry that into a restaurant every time?
This thing?
Yeah.
Oh, my yes, you bet. Makes patients nervous, or people nervous, too. All right, so something fun to try. And really, it's not like you're really doing anything invasive to somebody. But you got to work it. I've tried it, and you have to work it down and get it's going to work down the edge. If it keeps hitting the middle of the meat, you're not going anywhere. So you need to rotate it, and then eventually you feel it slip right on the pass, blow it up, and you can work it right out. Anyway, fun little thing. The gastroenterologists don't like it when I do that because I just say it costs them a $3,000 payment to their home. So C-spine stuff. Broken neck, you'll never have one, that kind of thing. Now the question we have is on the mountain, what do you do about broken necks and broken backs, or even better yet, the neck injury or the back injury? This is a huge pet peeve of mine, that we board people and collar people. Boarding people on the hill is an absolutely wrong thing to do unless you have 100% justification. You harm people by putting them on a backboard. I will promise you, you look at all the studies out there and they show you how much harm we're doing, not good, harm, by backboarding and C-collaring patients. You need to know what you're doing to put a C-collar on. It's not just that I was taught by my granddaddy and my EMS people in my town. Oh no, this is dogma, this is false doctrine. You have to know why you put a C-collar on. You show up in the ER with a medical problem, I don't stick a Foley catheter in you randomly. I don't stick an IV in randomly, hoping you might feel better. No, you have to have a clear reason behind it. Because if you don't, and you harm my family member, I will haunt you, I promise you. And if you want to see what harm you're doing, just come see your patient 3 or 4 days after you brought him to the hospital and see what you did to them by strapping to a backboard for prolonged periods of time. The rule is, if you put them on a backboard, they must be off in 30 minutes. Good luck on that one on the hill. All right? So this is why I'm not even encouraging people to have backboards up there or to strap people down. A nice foam pad on the ground works better than any backboard would. Now, if they want to fly them off the hill and just stabilize them for the flight, that's okay, because that's only a 15-minute flight. 30 minutes is your rule. So they look at different studies out there. You don't trust me? Nexus, Canadian C-spine rules. They look at thousands and thousands of patients and say, how effective are these things? Well, you look at the rules and they say, well, over 99%, they picked up clinically significant injuries. I mean, you can't get much better than that. So this is based on physical and history, not on x-rays, CAT scans. This is history, physical alone. And so you look at these questions. Is there a focal neurological deficit? I'm not going to read them. You should learn this somewhere else because we don't have enough time today. You go right on through it, you ask these simple questions, and you are done. You move on. The Canadian C-spine rules did the same kind of thing. They asked 3 questions. They didn't even touch their patients. They don't even touch them. Accuracy of the Canadian C-spine rules, absolutely wonderful. In fact, they said it was up to 100%. Some of the new evaluations who tried to critique them said, we think you're only 90%. But then they went back and did more studies and said, no, we're actually correct. We're over 98 to 99% effective on this. So I don't care which rules you're using. And if you're in Utah County, they are coming out in the new guidelines. So you don't have to backboard and C-collar all these patients. You're going to take grief from staff in the ERs who have no idea what they're talking about. But don't let them intimidate you. So this is kind of what I do, but again, we can talk about it later, but it's just, I do my assessments, but I don't put many people on backboards or C-collars in the field ever again. Rarely do I do it. All right. Let's just skip some of this C-spine. You can tell it's my pet peeve here. I thought I'd throw a bunch of them in, but... I'm reading as fast as I can. All right, so C-collars, if you need to put one on, let's say they've got some deficits, they've got localized step-off, deformity, they have localized midline C-spine pain, you know there's something wrong there, fine, make up your own C-collar. If you think the regular store-bought C-collars are nifty, well, they're not. They're designed for a price point. They try and make them a good product. But C-collars are designed to help you, remind you not to move your head. So be creative. All the different things you want to use. I mean, a lot of the things you might have, Sam splints, for example. Sam splints are wonderful collars. Clothing wrapped around, they're nice and snug. You can package it in any way you want. You can shove a sock here and a piece of underwear here until they're nice and snug. And it doesn't restrict your airways. You can get into a rolled hip belt. You can get into the insulate foam pads. You can cut up your own foam pad and make a C-collar. Just improvise. You don't have to have a